Imagine looking at those, squiggly lines on an ECG, an electrocardiogram, and just knowing what's happening electrically inside the heart. It seems like magic sometimes.
It really can, but it's not magic. It's about understanding the language.
Exactly. And today, we're doing a deep dive into how those squiggles get made and, crucially, what they actually mean. We'll be using the powerful lens of vectorial analysis.
That's right. We're digging into the concepts from Chapter 12 of Guyton Hall's textbook of medical physiology. It really lays out how vectorial analysis is the key to interpreting heart muscle issues, coronary blood flow problems, all from the ECG.
It's really the foundation that lets the pros look at an ECG and see the electrical forces at play, isn't it?
Absolutely. It moves beyond just pattern recognition.
So our mission here is to give you that same foundational grasp. Think of it like getting the decoder ring for those ECG lines. By the end, you should really understand why specific waves appear in specific leads and what that tells us about the heart's electrical state. We're aiming for that expert-level insight.
It's a truly powerful framework for thinking about the ECG.
Okay, let's unpack this. So to start decoding, we need the basic building block, the vector. In terms of heart electricity, what exactly is a vector?
Okay, basically, a vector here is just an arrow. Simple as that. It shows the electrical potential generated by current flowing in the heart muscle at, any specific moment.
An arrow showing direction.
Right. The arrowhead points in the positive direction where the current's heading, and its length. That's proportional to the voltage, the strength of that potential.
Well, direction and strength, but the heart's complex, right? Electricity isn't just flowing one way.
Precisely. As that electrical wave spreads, you've got different parts of the heart in different states. Some are depolarized negative on the outside compared to the positive outside of the resting or polarized areas. Current flows between these zones.
So lots of little currents happening.
Exactly. But the beauty of vectorial analysis is you can mathematically sum up all those tiny simultaneous currents across the whole heart.
And that sum gives you one overall arrow for that instant.
That's the one. That's the resultant vector, or what we call the instantaneous mean vector. It represents the net electrical force of the entire heart at that precise moment in time. So for instance, when the ventricles first start depolarizing, the impulse moves from the base towards the apex. Sum up the currents then, and you get a resultant vector pointing generally downwards and forwards.
Okay, base to apex. But how do we describe that direction, really precisely, not just down and left?
We use a standard degree system. Think of a circle laid over the chest. The reference point is horizontal, straight to the person's left. That's defined as 0 degrees.
0 degrees is straight left.
Okay, yep. And from there, we measure clockwise. Straight down is plus 90 degrees. Straight right is plus 180 degrees. Straight up would be 90 degrees, or you could call it plus 270. It gives us a consistent map.
So that vector pointing down and left would be somewhere between 0 and plus 90 degrees.
You got it. And interestingly, for a normal, healthy heart, the average direction of that vector during the main part of ventricular depolarization, the mean QRS vector, is usually around plus 59 degrees.
59 degrees.
Yeah, which tells us that for most of that ventricular activation time, the apex is effectively positive compared to the base.
Okay, so this vector is constantly changing direction and length as the heart beats. How does the ECG machine actually capture this? Through the leads.
Correct. ECG leads are just pairs of electrodes placed on the body connected to the machine. Each lead acts like a specific electrical viewpoint, a camera aimed at the heart from a unique angle.
And each camera angle, each lead, has its own fixed direction, like it's bolted in place.
Precisely. That fixed direction is called the lead axis, and it's defined as the direction from the negative electrode of that pair towards the positive electrode. Knowing these axes is absolutely fundamental.
Okay, let's map them out. The standard bipolar limb leads AT in the 3. Those are the classics.
Right. Lead eye connects the right arm, which is negative, and the left arm, positive. Since the arms are roughly horizontal across the body, its axis is that 0 degree reference point we talked about.
Lead eye looks straight left. Easy enough.
Lead 2 connects the right arm, negative, to the left leg, positive. So its axis points downwards and a bit left. It's around plus 60 degrees.
Okay. And lead 3?
That one's between the left arm, negative, and the left leg, positive. So its axis points down and more sharply left, about plus 120 degrees. You can visualize these forming a triangle, Einthoven's triangle.
Then there are the unipolar limb leads, AVR, AVL, AVF. Different setup.
Slightly different reference system, yeah, but they give us three more vital perspectives. AVR has an axis way over at plus 210 degrees, sort of up and right.
Okay.
AVF points straight down, exactly plus 90 degrees. And AVL points up and left at -30 degrees.
So if you picture all these axes radiating out from the heart, it's like spokes on a wheel.
Exactly like that. It's often called the hexagonal reference system when you plot them all. Knowing the direction of each spoke, and crucially, which end is positive and which is negative, is essential for interpretation.
Okay, this feels like the core connection now. How does that instantaneous heart vector, that single arrow at any moment, translate into the actual voltage squiggle we see on the ECG paper for a specific lead?
This is it, the absolute key principle. The voltage recorded in any lead at any instant is simply the mathematical projection of the heart's instantaneous vector onto the axis of that specific lead.
Projection. Like casting a shadow. Is that a fair analogy?
That's a perfect way to think about it. Imagine the heart's vector arrow floating there amongst all those lead axis lines. To find out what voltage lead eye sees, you project the heart vector onto the lead axis line.
How do you do that visually?
You drop a perpendicular line from the very tip of the heart vector down to the line representing the lead axis.
Okay, draw a line straight down to the axis.
Right. And the segment that creates on the lead axis, from the center point out to where your perpendicular hits, that's the projected vector. The length of that projected vector is directly proportional to the voltage, the ECG machine records for that lead at that moment.
Length equals voltage. What about positive or negative deflection on the trace?
That depends entirely on which way that projected vector is pointing along the lead axis. If it points towards the positive end of the lead axis, the ECG records a positive voltage. The line goes up.
And if it points towards the negative end?
Then it's a negative voltage. The line goes down below the baseline.
So, if the heart's vector happens to be pointing almost exactly along a lead's axis?
Big voltage. Maximum projection, long projected vector. If the heart vector points exactly opposite to the lead's positive direction.
Big negative voltage.
Exactly. And the crucial one, what if the heart's vector is pointing exactly perpendicular to the lead axis?
The shadow would be just a point, 0 length.
Precisely. The perpendicular line from the vector tip lands right back at the center point of the axis. The projected vector has 0 length. So the voltage recorded in that lead at that instant is 0, or very close to it. The ECG line stays flat.
Wow, okay. That geometric projection explains everything. It's why the same electrical event in the heart looks different. Big R wave here, small S wave there, maybe isoelectric somewhere else, depending on which lead's camera angle you're looking from.
You've got it. Once you truly grasp that projection concept and you know where the lead axes are, you can start to logically deduce why the normal ECG waves have the shapes they do. It's not arbitrary at all.
Okay, with that projection principle solid, let's look at the normal ECG waves, starting with the big one, the QRS complex. That's ventricular depolarization, right?
That's the main electrical event for contraction, yes.
Yeah.
The waves sweeping through the ventricles. And it's not instant. It follows a very specific sequence, creating a vector that's constantly changing in both size and direction throughout that brief QRS interval.
What's the sequence? Where does it start?
It kicks off in the interventricular septum, the wall between the ventricles. The impulse comes down the bundle branches, and the left side of the septum usually depolarizes just fractionally before the right.
Okay, left septum first.
Right. This happens really fast, maybe 0.01 seconds in. It generates a relatively small initial vector, often pointing a bit downwards, forwards, and sometimes slightly rightward. Projecting the small vector onto the standard leads gives pretty low voltages. In some leads, this might cause a tiny initial negative dip at the beginning of a Q wave.
And it spreads out.
Rapidly. By about 0.02 seconds, the depolarization wave is engulfing the rest of the septum and spreading outwards along the inner surfaces, the endocardium of both ventricles. Now you have a much larger mass of muscle becoming electrically active.
So the vector gets bigger.
Significantly bigger,
Yeah.
a much longer vector, and it's typically pointing strongly down towards the apex of the heart, generally downwards, leftwards, and a bit forwards. This larger vector, when projected, causes the voltages in the leads to rise sharply, forming the main upward R wave.
And as it moves through the main bulk of the ventricular walls.
By around, say, 0.035 seconds, the wave is propagating through the thick muscle towards the outer surfaces, epicardium. The vector is still large, still generally pointing towards the apex. Because the left ventricle is thicker and takes just slightly longer than the right, the vector might shift a bit more leftward during this phase.
How does that affect the leads?
The relative voltages change. For instance, the projection onto lead 50, 0 degrees, might get larger relative to lead 3, plus 120 degrees, as the vector swings more leftward.
Okay, almost done depolarizing.
Right. By about 0.5 seconds, the impulse is reaching the last bits of the outer walls, often near the base. The vector starts to shorten now because there's less polarized muscle left. Its direction might also shift back upwards or maybe more leftward towards the base as those final areas activate.
In this final shift.
This final vector shift, pointing away from the apex and maybe towards the negative end of lead 2 or 3's axis, can cause the voltage in those leads to dip negative, forming the S wave. Lead might remain positive if the vector stays left.
And then complete depolarization.
Exactly. By about 0.06 seconds, give or take, the entire ventricular muscle mass is depolarized. Now, all the cells are in the same electrical state, negative on the outside. There's no potential difference between areas anymore.
So no current flow.
No significant current flow. The instantaneous vector collapses to 0, and the voltages recorded in all leads return to the 0 baseline, ending the QRS complex.
So the QRS complex, the Q, the R, the S, isn't just a random shape. It's literally the ECG tracing the projection of that rapidly changing ventricular depolarization vector onto each lead's axis over time. The tall R is the main apexward vector, Q is the initial septal vector projection, and S is the final baseward vector projection.
That's precisely it. If you can mentally visualize that sequence septum, then bulk apexward, then final baseward vectors, and imagine projecting them onto each lead axis, 0, plus 60, plus 120 degrees, etc., you can understand exactly why the QRS looks different in lead I versus lead 2, and so on. It's pure geometry reflecting physiology.
Okay, QRS makes sense now vectorially. Let's move to the T wave. That's ventricular repolarization, the reset phase.
Right, the electrical recovery of the ventricular cells, getting ready for the next beat. This starts around 0.15 seconds after depolarization begins and finishes by about 0.35 seconds.
Logically, you'd think repolarization would just reverse the depolarization sequence. If activation goes base to apex, maybe recovery goes apex to base.
That would seem logical. But here's one of the most fascinating and initially counterintuitive aspects of cardiac electrophysiology. The sequence of repolarization in the ventricles is generally opposite to the main sequence of depolarization.
Opposite? How so?
The outer layers of the ventricle, the epicardium, especially near the apex, tend to repolarize sooner than the inner layers, the endocardium, and the septum.
Whoa. Why would the areas that depolarize last start recovering first? That seems backwards.
A leading explanation involves the mechanical pressure during contraction. The high pressure inside the pumping ventricles squeezes the blood vessels supplying the inner muscle layers, the subendocardium, more than those supplying the outer layers.
Okay.
This reduced blood flow, even slightly, might slow down the energy-dependent repolarization process in those inner layers compared to the outer layers, which have better perfusion during systole.
So the outer apical areas finish repolarizing first. They become electrically positive on the outside again, while the inner basal areas are still depolarized, still negative on the outside.
Precisely. Now you have an electrical potential difference again. Current flows from the still negative areas towards the newly positive areas, and the resulting repolarization vector points from the negative, still depolarized base inside, towards the positive, newly repolarized apex outside.
Wait, so the repolarization vector points from base towards apex.
Yeah.
That's roughly the same direction as the main QRS depolarization vector.
Exactly. It feels weird, but because repolarization makes the outside positive again, the vector points towards the areas becoming positive, first the apex and outer walls. Since this direction, down and left generally, aligns with the positive axes of leads 1, 2, and 3.
The normal T wave is positive in those leads, just like the main part of the QRS.
That's why. The normal T wave is typically upright, concordant with the QRS polarity in the standard limb leads, because the repolarization vector points similarly to the depolarization vector due to that reverse recovery sequence.
So the shape of the T wave itself, that broader hump.
That just reflects the repolarization vector growing and then shrinking over time. It starts small as the first few cells repolarize, reaches maximum length when about half the ventricle is repolarized, positive outside, and half is still depolarized, negative outside, and then fades back to 0 as the last cells finish repolarizing.
Mind blown slightly.
Okay.
Okay, what about the P wave? Atrial depolarization. Simpler.
A bit simpler, yes. Atrial depolarization starts at the sinoatrial SA node, which sits high up in the right atrium near where the superior vena cava enters. From that starting point, the electrical wave spreads outwards across both atria.
So the initial activity is top right-ish.
Yep. And as the wave spreads down and across towards the left atrium and the AV node, the overall net vector of atrial depolarization points generally downwards and towards the left.
Down and left,
Yeah.
like the main QRS and T vectors.
Broadly similar direction, yes. And since that direction is generally aligned with the positive camera angles of leads 1, 2, and 3.
The P wave shows up as a positive deflection in those leads normally.
Okay. The source material also mentioned an atrial T wave. So the atria are repolarized too.
They absolutely do. Atrial repolarization follows atrial depolarization. Now, unlike the ventricles with their superfast Purkinje highway system, conduction through the atrial muscle itself is slower.
What does that mean for repolarization?
It generally means that the area that depolarized first, the SA nodal region, also tends to be the area that finishes repolarizing first. So the top right area becomes positive again first during atrial repolarization.
Correct. Which means the atrial repolarization vector points backwards, generally opposite to the direction of the atrial depolarization,
Right.
T wave vector.
Opposite direction means?
It means the atrial T wave, if you could see it clearly, would normally be a negative deflection in leads Y and 3 opposite to the positive P wave.
If you could see it, why can't you?
Because atrial repolarization happens to occur at pretty much the exact same time as the much, much larger electrical event of ventricular depolarization, the QRS complex. The small negative atrial T wave is simply buried, completely obscured by the massive QRS signal on a standard ECG.
Hidden in plain sight, essentially. Okay, we've talked about instantaneous vectors and the average QRS direction. The term vectorcardiogram came up. What exactly is that showing?
Think of it as a more dynamic picture. Instead of just plotting voltage against time for one lead, like a standard ECG trace, the vectorcardiogram plots the actual path of the tip of the heart's instantaneous electrical vector as it changes in both length, voltage, and direction throughout the cardiac cycle, or usually just during QRS.
So traces out a shape, a loop.
Exactly. During ventricular depolarization, QRS, the tip of the vector starts at the zero center point, sweeps out to trace an elliptical loop as the impulse spreads through the ventricles, and then returns back to the 0 point when depolarization is complete. That loop is the QRS vectorcardiogram.
And the overall orientation of that loop, does that relate back to the mean electrical axis we discussed?
It does, very directly. The main or preponderant direction of that QRS loop represents the mean electrical axis of the ventricular QRS. So it graphically shows that average plus 59-degree direction for a normal heart, but also visually depicts how the vector deviates in abnormal conditions. It's a more complete two-dimensional view of the electrical forces.
Interesting. But you mentioned clinically, we often figure out the axis just from the standard ECG.
That's right. While vectorcardiography provides more detail, you can calculate a very good estimate of the mean electrical axis using just the standard limb leads, typically leads 1 and 3.
How do you get that single average direction number from looking at those sometimes complex QRS shapes in lead I and lead 3?
It uses the same projection idea, just in reverse, kind of. First, you look at the QRS complex in lead I and determine its net potential. You look at the upward R wave and any downward QRS waves. You basically sum the positive areas and subtract the negative areas.
Like, is it overall more positive or more negative, and by how much?
Exactly. You get a single net voltage value for lead I, say, plus 5 small squares, or maybe negative 2 small squares. You do the same thing independently for lead 3, calculate its net QRS potential.
Okay, got a net voltage for lead I and a net voltage for lead 3.
Now, you go back to that hexagonal reference system diagram with the lead axis drawn. You plot the net voltage for lead high as a point on the lead axis 0 degrees. Positive value goes out along the positive side, negative value along the negative side from the center.
Okay, point plotted on lead I axis.
Then you plot the net voltage for lead 3 as a point on the lead I axis, plus 120 degrees, again respecting the polarity.
Point plotted on lead 3 axis. Now what?
Here's the vector construction. From the point you plotted on the lead I axis, draw a line perpendicular to the lead I axis. Then, from the point you plotted on the lead 3 axis, draw a line perpendicular to the lead 3 axis.
Drawing two perpendicular lines. They should cross somewhere.
They should intersect at a single point. That intersection point represents the tip of the calculated mean QRS vector for that heart.
And the base of the vector is the center where the axes all meet.
Correct. So you draw an arrow from the center, 0 point, out to that intersection point. The direction of that arrow measured in degrees using our 0-degree reference, is the mean electrical axis. For a normal heart, that arrow should point somewhere near that plus 59-degree mark we keep mentioning. The length of the arrow also gives an idea of the average QRS voltage.
That's clever. So even from just 2 leads and some simple geometry, you can determine the average electrical direction of the ventricles.
Precisely. And while plus 59 is the average, remember the normal range is quite wide in healthy people, maybe from plus 20 degrees up to about plus 100 degrees. Things like body shape, heart position can cause variation within that range.
But if the axis calculated this way falls outside that, say, plus 20 to plus 100 range,
then we call it axis deviation. Left axis deviation if it's more negative than plus 20, like 0, 10, negative 30, etc. Or right axis deviation if it's more positive than plus 100, like plus 110, plus 150, etc. And that usually signals something abnormal is going on.
axis deviation is a potential red flag. What kinds of things cause it? You mentioned heart position.
Right. Sometimes it's just the heart's physical orientation in the chest. It's not necessarily disease.
Like posture or breathing.
Exactly. If the heart tilts more horizontally, maybe when you lie down or at the end of a full exhalation, or if someone is obese and the diaphragm pushes up, the whole electrical axis shifts leftward with it. That's left axis deviation, but maybe physiological.
And the other way.
If the heart hangs more vertically, like when you stand up or take a deep breath in, or in very tall, slender people, the axis shifts rightward. Again, potentially normal right axis deviation.
But often, deviation means something's up with the heart muscle itself, like hypertrophy.
Absolutely. Hypertrophy, meaning increased muscle mass in one of the ventricles, is a major cause of pathological axis deviation.
Why does just having more muscle on one side shift the whole electrical axis?
2 key reasons. First, simply put, more muscle generates more electricity, so the potential on that side is greater. But perhaps more importantly, for significant axis shift, the electrical impulse takes longer to travel through that thickened, hypertrophied muscle.
Longer travel time. So the normal side finishes depolarizing while the thick side is still going.
You got it. The normal ventricle depolarizes quickly, and its outer surface becomes electrically negative relatively fast. But the hypertrophied side is still slowly working its way through depolarization, so its outer surface remains electrically positive for a longer time.
So there's a sustained electrical difference pointing towards the slow, thick side.
Precisely. That creates a strong instantaneous vector pointing towards the hypertrophied ventricle for a longer portion of the QRS cycle. When you average all these vectors out, the mean axis gets pulled strongly towards that hypertrophied side.
So left ventricular hypertrophy, LVH, maybe from high blood pressure or aortic valve disease,
Causes left axis deviation. The calculated mean axis might shift way left, perhaps to negative 15 degrees, maybe even negative 30 or more, definitely outside the normal range. You'll also often see higher voltage QRS complexes because of the increased muscle mass, and the QRS duration might be slightly prolonged, maybe 0.09 to 0.12 seconds, due to that longer conduction path.
and right ventricular hypertrophy, RVH, maybe from pulmonary hypertension or certain congenital heart defects.
Causes right axis deviation. The axis can swing way over to the right, sometimes beyond plus 150 or plus 170 degrees, again, often accompanied by high voltage and maybe that slight QRS widening.
Okay, hypertrophy pulls the axis towards the thick side. What about the other major cause mentioned? Bundle branch block. That sounds like an electrical wiring problem, not a muscle size problem.
Exactly. The bundle branches are part of the Purkinje system, the heart's high-speed electrical conduction network that ensures both ventricles depolarize almost simultaneously. If one of those main branches, the left or the right, gets blocked.
The electricity can't use the fast lane on that side.
Perfect analogy. The impulse travels down the good bundle branch and depolarizes that ventricle normally and quickly. But on the side with the block, the impulse hits a dead end in the fast pathway and has to spread slowly, cell to cell, through the ordinary ventricular muscle itself.
So one ventricle depolarizes fast, the other depolarizes really slow. They're out of sync.
Totally out of sync, and that's the key. The healthy ventricle depolarizes rapidly and even starts repolarizing, while the block side is still laboriously depolarizing. This means the blocked side remains electrically positive on the outside for a much longer time, while the normal side has already become negative.
And just like with hypertrophy, that prolonged positivity on one side pulls the vector.
Exactly. The electrical difference persists for longer, creating a strong mean vector that deviates sharply towards the ventricle with the blocked bundle branch because it stays positive longer.
So left bundle branch block, LBBB.
The right ventricle depolarizes fast, the left is slow. The vector points strongly leftward, causing intense left axis deviation, often around -50 degrees or even more negative.
And right bundle branch block, RBB.
The left ventricle is fast, the right is slow. The vector gets pulled strongly rightward, causing marked right axis deviation, maybe plus 105 degrees or more.
Okay, wait. Both LVH and LBBB cause left axis deviation. But the RVH and RBBB cause right axis deviation. How do you tell them apart? Just by looking at the ECG axis.
That is a critical distinction, absolutely key for mastering this. The clue isn't just the axis deviation itself, it's the duration of the QRS complex.
The width of the QRS.
Precisely. With hypertrophy, the QRS might be slightly widened, as we said, maybe up to 0.12 seconds because the path is longer. But with a bundle branch block, because the impulse has to crawl through that slow muscle pathway instead of the fast Purkinje fibers, the QRS complex becomes markedly prolonged.
How prolonged?
Typically 0.14 seconds or even longer. That very wide, often strangely shaped QRS is the absolute hallmark of a bundle branch block. Hypertrophy usually causes axis deviation with high voltage and only mild QRS widening. Bundle branch block causes axis deviation with dramatic QRS widening. If you see a QRS wider than 0.12 seconds, you should be thinking conduction block almost certainly.
Got it. So the axis tells you the direction of the problem, but the QRS width helps pinpoint whether it's a muscle size issue, hypertrophy, or a conduction pathway issue. You need both pieces of the vector puzzle.
Absolutely. It's analyzing the average direction, axis, the magnitude, voltage, and the timing, duration, and shape together that gives you the full picture.
Speaking of magnitude, let's focus on the voltage of the QRS. What's normal, and what do high or low voltages suggest?
In those standard bipolar limb leads, IMI 2 and 3, if you measure from the very peak of the R wave down to the lowest point of the S wave, the total voltage is typically somewhere between 0.5 and 2.0 millivolts. There's definitely variability. Lead 2 is often tallest, lead 3 sometimes smallest, but that's the ballpark.
What if it's way bigger than that, high voltage?
Yeah, if you add up the QRS voltages in all three standard leads and the total is more than, say, 4 millivolts, that's generally considered a high voltage ECG. And as you might guess from our hypertrophy chat,
more muscle.
That's the most common reason. Increased cardiac muscle mass, usually from ventricular hypertrophy caused by chronic pressure or volume overload, just generates more electricity, more muscle cells firing, bigger overall signal.
So high voltage is another clue pointing towards hypertrophy, reinforcing the axis deviation finding.
Exactly. They often go hand in hand. The ECG in LVH or RVH typically shows both axis deviation and increased QRS voltage.
Okay, conversely, what about abnormally low voltage?
Low voltage can happen for two main categories of reasons. Problems within the heart muscle itself, reducing signal generation, or conditions surrounding the heart that dampen the signal before it reaches the skin electrodes.
Okay, problems inside the heart first.
Things that decrease the amount of healthy, electrically active muscle. A major one is an old myocardial infarction, a past heart attack. Scar tissue replaces muscle. Scar tissue doesn't generate electricity, so the overall voltage goes down. Plus, scar tissue can impede conduction slightly, which also contributes.
Makes sense. Less engine power.
Right. Also, certain diseases where abnormal stuff infiltrates the heart muscle, like cardiac amyloidosis, can interfere with normal electrical function and reduce the voltage output.
Okay, so damage or infiltration within the heart. What about conditions outside the heart?
This is really important clinically. A classic cause of low voltage is pericardial effusion excess fluid building up in the sac around the heart.
Fluid around the heart dampens the signal. How?
The fluid is conductive, and it essentially acts like a short circuit. It allows some of the electrical potential generated by the heart to dissipate within the fluid layer, so less of the signal actually makes it out to the body surface where the electrodes are.
Interesting. Like an electrical muffler.
Kind of, yeah. Similarly, very large pleural effusions, fluid around the lungs, can sometimes have a similar, though usually lesser, dampening effect. And then there's pulmonary emphysema.
How does emphysema cause low voltage?
In severe emphysema, the lungs are overinflated with air. Air is a terrible conductor of electricity. It's an insulator. These big air-filled lungs might also surround the heart more completely than usual. So the electrical signal from the heart has trouble getting through that insulating layer of air to the chest wall electrodes. Result: low voltage recorded on the ECG.
Fascinating. It really highlights that the ECG is measuring electricity at the skin, and anything between the heart and skin can influence what we see.
It's a crucial point. You always have to consider the whole patient picture, not just the ECG in isolation.
We touched on QRS duration with bundle branch blocks. Let's just nail down the timings. Normal duration is
Really short. Normally, the entire process of ventricular depolarization reflected in the QRS complex takes between 0.06 and zero point zero 0.08 seconds. Super fast, thanks to that Purkinje system.
And hypertrophy or just general heart enlargement might stretch it a bit.
Yeah, if the impulse has physically further to travel through thickened or dilated walls, the QRS might widen slightly, maybe into the 0.09 to zero point 0.12 second range, still relatively quick.
But the big jump in duration is the sign of a conduction block.
Absolutely. When the fast Purkinje highway is blocked and the impulse has to take the slow local roads through the ventricular muscle, which conducts at maybe a third of the speed the time it takes to activate the whole ventricle skyrockets, that's when you see QRS durations of 0.14 seconds or more.
So clinically, a QRS duration creeping over 0.09s is noteworthy, maybe prolonged. But once it hits 0.12s, or especially 0.14s,
you are almost certainly dealing with a significant pathological block in the conduction system, like a bundle branch block. That marked widening is a key diagnostic feature.
What about QRS complexes that aren't just wide, but look weird, bizarre shapes, multiple peaks or notches?
Those usually indicate a really chaotic or irregular spread of the depolarization wave. Instead of a smooth, coordinated activation, the impulse might be taking detours, hitting dead ends, or spreading unevenly.
What causes that kind of chaos?
Often it's due to destruction of heart muscle, like areas of scarring from previous heart attacks. Scar tissue doesn't conduct well, if at all, forcing the impulse down abnormal pathways. Another cause can be multiple small, scattered blocks throughout the Purkinje system, maybe from diffuse coronary disease. This patchy conduction leads to the instantaneous vector jumping around erratically, creating those notched, fragmented, or multi-peaked QRS patterns.
So QRS duration tells us about the overall speed of conduction, while bizarre morphology tells us about the smoothness or regularity of the vector's path.
That's a great summary. Both provide crucial information about the integrity of the ventricular conduction system and muscle.
Okay, shifting gears to something that sounds really critical for emergencies. The current of injury. What exactly is this current? Why does it happen between heartbeats?
A current of injury is fundamentally different from the repolarization currents. It's a flow of electricity that exists continuously even when the healthy parts of the heart are fully rested and polarized specifically during that flat TP interval on the ECG before the next P wave starts.
A continuous current when the heart should be quiet. How?
It happens because some part of the heart muscle is injured or severely ischemic to the point where it cannot fully repolarize after a beat. It remains stuck, partially or fully depolarized all the time.
So it stays electrically negative on the outside, even when the surrounding healthy muscle has reset and become positive on the outside.
Exactly. You've got this island of persistent negativity, the injured area, surrounded by positivity, the healthy resting area. That electrical potential difference drives a continuous flow of current between the healthy and injured zones. That's the current of injury.
What causes that kind of persistent damage?
It can be caused by direct physical trauma, or maybe an infection damaging the muscle cells. But far and away, the most common and clinically vital cause is local coronary ischemia, lack of blood flow.
So a blocked artery.
Right. If a region of heart muscle is starved of oxygen and nutrients because its coronary artery is blocked or severely narrowed, its metabolism fails. The cells can't maintain their normal ionic balances and membrane potentials. They may not be dead yet, but they can't repolarize properly and stay persistently depolarized.
And this continuous current flow.
Yeah.
How does it manifest on the actual ECG tracing?
Because there's a steady electrical vector present even during the TP interval, when the normal heart's vector is 0, this injury vector creates an effect. Its projection onto the different lead axes shifts the apparent baseline of the ECG during that normally flat TP segment.
The flat line between beats isn't flat anymore. It's shifted up or down.
Precisely. That baseline shift is the sign of the current of injury. The steady injury vector is always there, and its projection onto each lead determines how much that TP baseline is displaced from true 0.
Okay, but that creates a measurement problem, right? If the baseline we normally use for reference is itself shifted, how do we know where true 0 voltage actually is? How can we measure anything accurately?
Excellent question. That's exactly the problem. And the solution lies in finding a moment in the cardiac cycle where we know the potential difference causing the injury current temporarily disappears. That moment is the J point.
The J point. That's the very end of the QRS complex, right, where it transitions into the ST segment.
Correct. That precise instant.
Why is that point considered the true 0 reference when there's a current of injury?
Think about what's happening electrically at the J point. The wave of depolarization, which creates the QRS, has just finished sweeping through the entire ventricular muscle mass. This includes the healthy muscle and the injured, persistently depolarized muscle.
So for that brief instant, everything is depolarized.
Exactly. Both the normal cells and the injured cells are in the same depolarized state, negative outside. Because there's no potential difference between any parts of the ventricle at that specific moment, the current of injury itself momentarily vanishes. There's no flow between injured and healthy tissue because they're both in the same state.
The J point is the instant of universal depolarization, wiping out the injury potential temporarily. So the voltage level at the J point must represent the true zero potential for that beat.
That's the logic. So clinically, when you suspect a current of injury, because the PP or ST segment looks shifted, you identify the J point on the tracing in each lead. You then draw a horizontal line through that J point. That line becomes your true 0-volt reference line for analyzing that beat.
Okay, J point line is 0. Then you measure the shift.
You measure the voltage difference between the actual TP segment, or more commonly the ST segment immediately following the J point, and that J point reference line. That difference is the injury potential voltage for that lead. You note its magnitude and polarity. Is the ST segment elevated above the J point line or depressed below it?
And once you have those injury potential voltages for a couple of leads, say lead I and lead 3.
You can perform vectorial analysis on them. You plot those measured injury potential voltages, plus or blank, on the respective lead axis, lead I axis, lead 3 axis, in the hexagonal system, just like we did for the mean QRS axis. Draw the perpendiculars from those points.
Find the intersection point. Draw the vector from the center to that point. And that gives you the resultant vector for the current of injury.
Precisely. You've calculated the direction and magnitude of the average current flowing due to the injury.
What does the direction of this injury vector tell you? This is the crucial part.
This is the absolute key for diagnosis and localization. The negative end of the resultant injury potential vector points directly towards the area of heart muscle that is injured and remaining depolarized.
Negative end points to the damage. So if the vector analysis shows the negative end pointing towards the front of the heart,
that indicates the injury is on the anterior wall. If it points towards the back,
posterior wall injury. If it points down towards the bottom,
inferior wall injury. It allows you to electrically see where the damaged ischemic tissue is located.
And we know this injury is most often caused by coronary ischemia, lack of blood flow. So this is the electrical fingerprint of an acute heart attack.
Yes. Seeing a significant current of injury typically manifesting as ST segment elevation, if the injury is full thickness, transmural, or ST segment depression, if the injury is mainly in the inner layer, subendocardial. Relative to that J.0 line is a critical sign of acute coronary ischemia or infarction. Analyzing the vector of that ST shift is paramount for localization.
Let's walk through an example. Say, acute anterior wall infarction. What would the injury potential look like?
Okay. Anterior wall. That's the front of the heart. The chest leads, like V1, V2, V3, V4, are looking right at it. If the anterior wall is injured, it's persistently negative. The injury vector's negative end points towards it. This means the vector itself points away from the anterior wall, maybe posteriorly or inferiorly.
So the projection onto those anterior chest leads.
The vector is pointing away from their positive electrodes, so you'd see ST segment elevation in those leads. The ST segment would be pushed up relative to the J point, indicating the vector's positive end is pointing towards those leads, while the negative injured end is pointing away deep into the anterior wall. Limb leads would help refine the location. For example, maybe negative potential in lead 1, positive in lead 3 suggests vector near plus 150 degrees, consistent with anterior injury.
Okay, ST elevation in leads facing the injury means the negative end points towards the injury. What about a posterior wall infarction? The back of the heart.
Now, the injury is on the back. The negative end of the injury vector points posteriorly. The vector itself points anteriorly towards the front chest wall.
So in those anterior chest leads, V1, V4,
they would see the positive end of the injury vector coming towards them. This means the ST segment would be depressed relative to the J point line in those leads. ST depression in anterior leads can be a sign of posterior injury. Limb leads might show ST depression in Tuthorn 3 maybe, suggesting a vector pointing upwards, like negative 95 degrees, consistent with the negative end pointing down and back towards the posterior wall.
So the rule holds. Find the J point, determine the ST elevation or depression, calculate the injury vector, and the negative end points to the damage zone. Allows incredible localization.
It's a cornerstone of acute ECG interpretation. These changes can evolve rapidly, but identifying that current of injury vector is vital for immediate diagnosis and guiding treatment like reperfusion therapy.
Does the injury current stay forever after a heart attack?
Usually not at its initial intensity. The very strong ST elevation or depression seen acutely often starts to diminish within hours or days and might resolve over weeks, especially if blood flow is restored or collateral circulation develops. This suggests the severely ischemic tissue has either recovered or completed its infarction process.
But if it doesn't go away, if the ST segments stay shifted,
Persistent ST elevation, for example, might suggest an aneurysm has formed in the scarred area. Persistent ST depression, especially if it worsens with exertion, strongly suggests ongoing chronic ischemia in that region.
in Q waves, you mentioned those earlier in relation to old damage.
Right. Pathological Q waves, abnormally deep or wide initial negative deflections in the QRS, are often a sign of a previous completed infarction. When muscle dies and becomes scar tissue, it's electrically inert.
So the initial depolarization wave has to go around it.
Exactly. This detour changes the direction of the very first instantaneous vectors of ventricular depolarization. They might now point away from the region of the old scar, causing a negative Q wave to be recorded in leads that look at that area.
So a Q wave in lead, I might suggest an old anterior scar.
Generally, yes. And a Q wave in lead 3 might point to an old inferior or posterior infarct. So while the ST segment shift, current of injury, is the hallmark of acute injury, pathological Q waves, along with possibly reduced QRS voltage and maybe persistent QRS widening or bizarre shapes, are the electrical scars of an old infarction.
What about angina? Chest pain from temporary ischemia, does that show up?
Yes, it can. Angina is usually caused by temporary exercise-induced ischemia where oxygen demand outstrips supply through narrowed arteries. During the episode of chest pain, the ischemia can be significant enough to impair repolarization in the affected area.
Leading to a temporary current of injury.
Exactly. You might see transient ST segment depression or elevation only during the pain, which then resolves when the pain goes away and blood flow balance is restored. It's a temporary vectorial shift reflecting temporary ischemia.
So even fleeting changes are detectable and meaningful. Okay, last major topic. T-wave abnormalities. We know the normal T-wave depends on that specific outer to inner repolarization sequence. What messes that up?
Anything that alters the relative timing or sequence of repolarization across the ventricles can change the T-wave shape or polarity.
Like the bundle branch blocks we talked about, slow conduction on one side.
Perfect example. Remember, in BBB, one ventricle depolarizes much later. Even if the cells themselves repolarize at a normal rate, the timing is thrown off. The ventricle that depolarized first, the normal one, will also tend to finish repolarizing first.
So the normal side becomes positive again while the slow side is still negative or still depolarizing.
Right. This creates a repolarization vector pointing from the slow side towards the fast, already repolarized side. This direction is generally opposite to the main QRS depolarization vector, which points towards the slow side.
Opposite QRS direction means opposite T-wave polarity.
That's the result. In LBBB, the QRS vector is strongly leftward, but the T-wave vector often points rightward, causing inverted T-waves in leads where the QRS is upright. In RBBB, QRS is rightward, T-waves often inverted where QRS is upright. It's called secondary T-wave change, a consequence of the altered depolarization sequence. If conduction is significantly delayed, wide QRS, T-wave polarity opposite to QRS is expected.
What else besides conduction delays can alter repolarization timing?
Changes in the duration of the action potential itself in different regions. Normally, action potential duration is relatively uniform. But if some area has an abnormally short action potential duration...
It finishes repolarizing sooner than its neighbors, out of sync.
Exactly. It becomes positive on the outside first. For instance, if the base of the heart somehow repolarizes significantly faster than the apex opposite of normal, the repolarization vector would point from apex towards base.
Opposite of the normal T-wave vector.
Right, and that would cause inverted T-waves in leads like I, and 3, where they are normally upright.
What would cause localized shortening of the action potential like that?
Mild ischemia is a very common culprit. Even ischemia not severe enough to cause a full current of injury, ST shift, can mess with the ion channels, particularly potassium channels, in a way that speeds up repolarization and shortens the action potential duration just in the affected area.
And if that happens unevenly?
You get T-wave abnormalities.
Okay.
This is why T-wave changes like flattening, inversion, becoming negative, or becoming biphasic, partly up, partly down, are often the earliest and most sensitive ECG signs of myocardial ischemia. They reflect subtle disturbances in repolarization timing caused by inadequate blood flow.
So T-wave changes can be a crucial early warning sign.
Absolutely. Especially if they are new or changing, they often indicate underlying coronary artery disease, even if the person isn't having acute symptoms.
Lastly, the source mentioned digitalis affecting T-waves.
Yes, digitalis is a medication used for heart failure and arrhythmias. In therapeutic doses, it can cause some characteristic, though usually mild, P-wave changes. But in overdose or toxicity, it can significantly and unevenly prolong the action potential duration in parts of the ventricle.
Prolonging it unevenly also disrupts the sequence.
Correct. It throws off the synchronized repolarization, leading to various non-specific T-wave abnormalities, often inversion or biphasic shapes. Seeing these develop can be an important clue to digitalis toxicity.
Wow, okay. We've journeyed from a simple arrow of the vector and seen how analyzing its projection, direction, magnitude, and timing unlocks this incredibly detailed electrical story of the heart.
It really does. From understanding the basic PQRST shapes through normal depolarization and that tricky repolarization sequence, to diagnosing hypertrophy and conduction blocks using axis and duration, and then pinpointing acute life-threatening injury using the current of injury vector, it all stems from these vectorial principles.
This wasn't just about memorizing ECG patterns, was it? It was about getting the why behind them, understanding the electrical engine driving it all.
Exactly, and here's where it gets really interesting. The sheer diagnostic power and anatomical precision you can gain just by rigorously applying these vector concepts is phenomenal. It lets you infer specific problems in specific locations.
So what does this all mean for you listening? It means those ECG squiggles aren't random noise. They are a direct, quantifiable language the heart uses to communicate its status. Learning vectorial analysis is like learning the grammar of that language, empowering you to interpret it with the kind of depth the experts use.
It truly transforms the ECG from a confusing trace into a powerful diagnostic window.
And here's a final thought to ponder. We've seen how vectors reflect the heart's state, even temporary states like angina. Considering how sensitive this electrical activity is, how might advanced continuous vector monitoring, perhaps using wearable tech or sophisticated algorithms, allow us to detect subtle signs of impending heart trouble even earlier, catching those slight vector shifts before they become a major clinical event? Something to think about.
Thank you for joining us on this deep dive into ECG vectorial analysis.
We really hope you now feel more equipped to look at an ECG not just as lines, but as a dynamic map of the heart's electrical life.